All right, Oliver, can I hand over to you?
Thank you. I appreciate that. It was zoomed in on an empty chair there as though to sort of shame me for not being there. I apologise for not being in the room in person. I'm down in London in the Home Office, and I actually thought I'd be able to dial in on the tech that they've got down here, but we couldn't make that work. So I'm dialing in on my phone. So apologies for that as well. Is everybody there? Can we start the meeting? Are we good, Piers?
Yeah, that's fine.
Brilliant. Okay, thank you. So just in terms of a welcome, so I've just got a few comments if that's okay. I suppose just about where we are right now, which is I think in a good place. I was down yesterday for the UK Investment Summit, managed to get some FaceTime with both Wes and with Amanda Pritchard, which was good. And we said we'd follow up in person, so I was positive about that. And there's clearly a huge amount of energy that's happening. Not all of it's easy, I appreciate, but definitely a huge amount of energy going into the conversations about what comes next. And we are part of those conversations and talking to the government increasingly about kind of what comes next, not just in the health space, but more broadly, as you'd imagine, through the MCA. But it was a good conversation yesterday, nonetheless. So I thought it was just worth touching on what was laid out in the Darcy report, which has been released since we last met, which is, I think, a moment of reflection, but also, again, a huge opportunity for South Yorkshire. I think what we have here in South Yorkshire is a huge number of assets that the government will want to build on, and expertise and opportunity they want to access, and seeing that they can use devolution to give us some of that opportunity going forward is a big thing. I was with the Prime Minister on Friday at the Council of Nations and Regions, actually talked to him about health and what we're doing here. I was with the Deputy Prime Minister the day before at the Council of Mayors, and again we talked about health and what we want to do in the health space. And yesterday I was talking to Liz Kendall about the Pathways to Work Commission, which you'll be aware of, which is one of those things that we're also hoping to take forward in South Yorkshire too. Obviously it's not all positive news. The Darcy report is a fairly bleak reminder of the state of the NHS, and it paints a fairly poor picture of the state of the health system, the state of the population's health. And in South Yorkshire, we know that that is also incredibly true, sadly. Health inequalities in South Yorkshire, as we all know, are stark, and too many people living too short lives in too poor a health, and it has to stop. Darzy's prescription is to develop a 10-year plan that focuses on promoting and creating good health with 3 critical shifts: a move to care from hospital to home, a move from from analog to digital, and a move from treatment to prevention. And that is a 10-year plan because there aren't any quick fixes. It was interesting yesterday, Wes was very clear, and I know he said this elsewhere, but very clear that he's got 2 significant work streams, one of which is to get a grip on the current system and make sure that things work today, or as quickly as possible today. And then the second bit of that is for us to get a grip on the 10-year challenge and how we make sure that the NHS doesn't fall over and systems don't fall over, because demand just goes through the roof. And so we've got to be able to work with the government on both of those strategies. In South Yorkshire, we have a huge number of strengths, not least this partnership, which has been showcasing its work right across the 4 local authorities. We've got things like Beds for Babies now up and running, which I am personally hugely proud of, making sure that every single child across South Yorkshire under 5 has access to a safe place to sleep is no small thing, but hugely important and a real trailblazer. This week sees the first people receiving our Workwell service, delivered in partnership between Simca and the ICB, and that's one of only 15 vanguards nationally. Innovation, we have our showcase in November with 80 exhibitors from across South Yorkshire, so there's a huge amount for us to build on. But we know from the discussion at our development session where we last met in July, a key role of this partnership is to be more effective at getting our region to be working better together, and that is clearly in the interest of everybody to do that, and most importantly for the members of the public of South Yorkshire. I know that there are going to be some people, some of the press in particular, who might be slightly cynical about how any new approach is going to be different. And I know that everybody feels like they've been through this before. But what I'm seeing genuinely in this government is that there are some things they're very clear about in terms of what they want to do. They're looking to places like South Yorkshire, increasingly mayors in general, but systems like ours, to show them the way and do things differently and test and learn. And Pathways to Work is a very good example, but we also need other areas where we can show through this partnership, through health and wellbeing boards, place partnerships, to make that shift there's not one place that should be or could be doing this alone. We need to work together to do all of this. I do think our integrated care strategy puts us ahead of the game. We've got bold ambitions and genuine vision in there. I think that's really important. But we need to use this opportunity, and it is an opportunity, and it is a short window of time to really kind of grab the opportunity in front of us to work with the government on doing things differently, show them how it can be done, and then get things going. And I get that that's not easy. We've got the conclusions of our Health Equity Advisory Panel report, the HEAP, that Alan Walker has been leading on. That'll be published soon. That'll help us, I think, to think through that challenge and move the dial on shifting care from hospital to home, moving our methods and systems from analog to digital, like I say, and our approach from diagnosis to treating and to predicting and preventing. So that's very much the theme of that. Very much looking forward to seeing that report out into the wild, and then building on it, and then working with the government to deliver on some of those strategies. So all good stuff. Anyway, that's my introduction. Item number 2 is any declarations of interest. Has anyone come into a huge amount of pharmaceutical shares in the last few months? No? Okay, perfect. Thank you. Meetings and the minutes from the meeting on the 29th of May. Has anybody got any amendments or challenges or changes to that? No. Okay, in which case, action log, please. I don't know if someone's going to read us through the action log. Yes.
Andrew.
Just there is one action in progress that's got as a key person, Kathy Cardle, who's now left, and I was wondering who was going to ensure that that would get done.
Thank you. Does anyone have an answer?
Oliver, we'll pick that up outside. The answer is I don't know, but it's a fair point, Angela. We'll pick it up outside and let you know.
Well, thank you. Any other anything else anybody wants to raise at that point about minutes or anything else? Follow? No? Okay, well. In which case, item number 4 is questions from the public. To receive questions from the public. Do we have any questions?
No, we have none, Oliver.
Brilliant. Thank you. In which case, item number 5 is about brief introduction why prevention is important. I believe Rachel is going to lead us through that, and to particularly think about how to do differently do things differently, and why that is just so important. So Rachel, would you mind leading us through that discussion, please?
Of course, thank you, Oliver. And I'm just checking if we've got the slides up on the screen as well. Great, thank you. And I think just clicking a couple through and a couple more. Brilliant, thanks everybody. So I'm Rachel Leslie, I'm Director of Public Health at City of Doncaster Council, doing this slot for Ben Anderson from Rotherham, and thanking him for some of the slides that make up the presentations today. So why is prevention important? You'll notice on the agenda for today it says a brief introduction. I promise you it will be brief, but there are some important things to cover as well. So I'll answer the exam question about prevention, and hopefully there'll be some things on those slides that you recommend that you recognise from previous conversations. I'm also going to talk about health inequalities and equity, because no conversation is right about prevention to not include health inequalities. And then the other bit, which is the true challenge around the acting differently bit. So I'll finish on some slides about how we explore the challenge of acting differently to achieve that left shift to prevention. So first proper slide, please. So starting with hopefully the bold ambition that you'll all recognise from the strategy, we'll be picking up some of the areas within the strategy today with some presentations, but just wanted to centre all of our thinking around that shared understanding of prevention of what. And I'm hoping that the answer is all of those things, because they are all linked. So prevention of early death, prevention of poor health, early poor health, particularly impacting South Yorkshire, prevention of demand on the health system, but also those links to economic inactivity, and for younger people as well, the lack of opportunity through their whole lives. The Acting Differently really want people in the room today and online today to think about what can be done at South Yorkshire level that can't be done at local level. So there's great stuff, as we all know, happening at local level, but there's a limit about what we can achieve with modest public health budgets and some of the roles and responsibilities that we've got at local level. So what can be done at South Yorkshire level that can't be done at local level, or not as well or efficiently at local level? And as well, how do we do that shift to the left of prevention, which I think we've tried various things before, and it's not a simple fix. So my last slide will start to introduce that too. Next slide, which I think is the pyramid. So with that dictionary definition of prevention for health, so helping people to stay healthy, happy and independent for as long as possible. Hopefully you'll all recognise as well the triangle of primary, secondary and tertiary prevention. So right at the top there, evidence-based treatments that will extend life and quality of life. Later is your tertiary prevention. At the very bottom of that pyramid there, looking at those structural and systematic factors, which I think is the opportunity for place-based working as well for our what can we do differently at South Yorkshire level. Just picking through three of the points there. So air quality particularly, there's a number of things that we can do around individual risk factors, and there's a number of things that we can do around legislation, enforcement and restriction of hazardous activities, as well as changing local environments as well. So what are our opportunities at place-based level for structural and systematic change? Next slide, please. And this is again the exam question response. So why is prevention important? You'll have all, I expect, seen examples of this before about health conditions that are largely preventable. 40% of cancers in the UK preventable, and we'll hear about smoking later and what impact that has on health and healthy life expectancy. And again, the bit about the link to the economic inactivity and lack of opportunity, as well as thinking about our working age population, thinking about our children and young people as well. So the impact of potential lack of opportunity for children and young people. Next slide. I told you I'd talk to you about health inequalities. I won't read through all of these, but just to describe about any approach to prevention must also be a pro-equity approach. So focusing on those, I've put core 20+5, however you recognise that, but those that live in our poorer neighbourhoods or those that are further away from health services, those that are affected by the places that they live. So anything that we do around prevention also needs that pro-equity focus too. Next slide. And the importance of why that is just to see the most deprived and the least deprived neighbourhoods and the proportion of life that people are spending in poor health, ill health in our poorer neighbourhoods. So making that both economic but also moral case for having that pro-equity focus. So next slide, thank you. So looking at here, and I've asked what can be done at place level. So really focusing on the systems and structures, the wider determinants of health and commercial determinants of health as well. So looking at that, all the aspects of housing, employment, income, transport, education. So all those elements, access to green space as well. You might not be able to read it on the screen in the room, but wanted to include some of the stats from our Doncaster Fairness and Wellbeing Commission that concluded last year that looked on income, medium income levels across different people living in Doncaster and how that matched to real living wage. So I've included that there just for some of that context too. Next slide. Acting differently. So this is a slide about complex systems. I can see that some of the formatting is slipped a little bit, but hopefully you can still recognise and read there. So in that very top corner, some of you might recognise the whole systems approach to obesity, the foresight model that was developed that describes all of the elements that have an impact on somebody's weight or healthy weight. So we'll recognise there that we often approach things in a person's life in those little pie chart squares or corners. We've each got different responsibilities, different actions and different remits. However, the whole person lives within that whole pie chart of things that happen to them. So again, asking this group as we go through today, what can be done at South Yorkshire level that enhances, but also the last bit about what will it take to realise that left shift. And then I think I've got one more slide. So this is our challenge for today. So what will it take to realise that left shift? It's not more evidence, the evidence for prevention focused things are some of the best evidenced things. So best evidence in terms of effectiveness and also cost effectiveness and return on investment. So it's not about the case of more evidence for these prevention focused activities. It might be, or it may be more resources, but that shouldn't be an excuse as to not get on with things that we need to do. There are resources in the system. It's about them being in the right place. And the tick there about it being about the bold stuff. And I think this is where we need to really get into as a group where the change can happen. So some of the simple things, or not simple, but simple things to say that you've heard before about that shift in spend from our acute sector, from the gritty end of things into that primary and community health creation focused activities. I think there's something there about revisiting where the power and the resources are in the system, question things like status quo and inertia. Why have we not been able to manage left shift before? What's made that system so complex? There's things to examine around leadership and clinical leadership as well. Things about low value interventions that are in place, and examining the clinical effectiveness of some of the things that we do, which might be right for the patient, but need to have that wholesale and an agreed view on that. And then the bit that we've seen as well about treating a person as a person and not just as a condition, so that multi-morbidity approach to epidemiology. So often people have more than one condition and will go around to different things and different services to fix or to address that. However, if we look at a person, what's the best way that we can support and treat and respond to that person? And then just two bits that I wanted to share as well. So my call today for the group would be more on that cause of causes, moving away from what's called lifestyle diseases and more onto those systems and the places that people live in and that health creation, and including the commercial determinants of health as well that strongly shape the choices that are available to people. And I just wanted to give a last call as well around compassionate approaches. So in Doncaster, we're taking compassionate approaches to various things, including obesity, and have had some press interest in that recently. So taking the blame away from people as a real opportunity to refocus and look at what we do. So offering that up as a second part of the consideration. So just finally, I know some of you have been looking at the Health Foundation reports recently as well, and I think some of this that I've presented today matches some of the calls for that as well. So just again, for the group, I think I've made the case on why we should focus on prevention. I think I've made the case for the health inequalities pro-equity focus, and then bringing that challenge to the group as well around the acting differently and the bold stuff. Thanks, Chair.
Thank you, Rachel. Really appreciate that. So I think we're all probably sold on the idea to do the left shift. The question is why haven't we? And I'm conscious we've only got now 6 minutes for this remainder of this discussion, which probably isn't enough time for us to make a decision about why we've not got there. But I just wonder if there's probably time for a couple of kind of interventions or comments, and Rachel's come back. But I just wonder if people might just take away the question, what one thing could we do more immediately to act differently? So I'm conscious that when we did the Beds for Babies work, one of the ways that we did that was bring everybody together and say, look, there's got to be a way into this challenge of health inequalities. And actually what we decided was the Beds for Babies scheme was the way into that challenge. But I wonder what else we could do. What is the one thing that we could shift in the system? We could collectively say this is the one thing we're going to do differently, and it doesn't have to be, the massive big thing. It probably needs to be one small thing that we can show people that we can actually, if we want to, put our brains together and find one thing and fix it. So not suggesting that people will be able to come with that right now, but we might want to revisit that, or if people want to email me or Stephen and just kind of put their thoughts forward, I'd appreciate that, because I think it's probably how we could start to behave differently. Piers, would you mind just kind of coordinating this kind of conversation in the room rather than me trying to do that?
Happy to do that, Oliver. I've got Angela first. Angela.
Yeah, thank you so much, Rachel. I think, you're preaching to the converted here. So we are all, on board with this. Is the big question is how do we do it? And I think whilst I agree with Oliver that it would be good to find something where we can demonstrate that we can make that change rapidly by doing something differently, I think it is also operating within a system that doesn't allow for prevention, because most resources are utilized in acute services in particular. So we focus on the obesity, for example, but we don't we don't focus on why people become obese and, you know, how many things influence that, as an example. So for me, it's also we have to challenge the system. So maybe as an ICP, we can, you know, through Oliver maybe, or through Gavin. I don't know, Gavin, you got a question at the Health and Wellbeing Board in Sheffield exactly on this. What do we need to do to shift those resources? Because that's the only way to do it. If we keep putting the resources all where we're putting the resources now, it's never going to change. However many little things we do, we're never going to change the big picture. That is where people live and how they live and the conditions they're in and the poverty, etc. Thank you.
Alexis.
Yeah. So I just want to say, first of all, thank you for the presentation work. It's absolutely excellent, really helpful to take us forward. I agree with you about the shifts in terms of funding. I think there's something about how we look wider than the system that we have here, and we look at some tangible projects. So, for instance, in Sheffield, we have the Homers programme and also Changing Future, which are about tackling multiple disadvantage and also trying to prevent homelessness occurring. And what we've actually managed to do is gain funding from a range of different sources to go and take these forward. And that's been about how we've tangibly been able to get into that left shift. But by using funding, it's not of the usual system, but working with system partners. So I think there's something about how we think in that mindset also, and also make some links to the wider safeguarding agenda, because when I look at that, I also align to how do we prevent the harm in terms of safeguarding and preventing death. So I do think there's making some synergies after this would be really quite helpful to do. And we'll link afterwards, because I am the lead for the prevention project. So we'll link afterwards to look at what we can do. And I would say that it would really be helpful if we could get programmes or projects across South Yorkshire that would actually go and help us to tangibly show how we're making the shifts, and then we could build upon strengths across South Yorkshire.
Joanna.
We need to do is prevent people's health from actually deteriorating more. I think missed hospital appointments because people can't afford the bus fare is something we really need to look at. So could we not have a South Yorkshire mayoral combined authority travel pass, which goes in with the appointment letter, which enables the person, their dependents or any carers to travel free to their appointment and back again?
Let me just say something before I finish. I think the challenge is the one Angela raised, which is we all know we should do it, but we failed to do it for several years. This is not something that's new. And I think there's a major dilemma for us. It's for the new government as well, post Darcy, which is whilst demand keeps going into acute care, demand that we all want to be dealt with more quickly and more efficiently. We don't want longer waits. We don't put the money in, we don't take the money out of acute care and put it into community and prevention. That dilemma is the dilemma we face. It's the reason I would argue the NHS, though it's talked about this forever, and I've been in the NHS for a long time, 1980, we talked about it in 1980, but we haven't really made a shift. It's managing that I think is our biggest challenge. The Darcy report was very clear that we need to do it. Actually, the mechanics of managing it is something we just need to be open with each other about, because it's very difficult. Eleanor.
Yeah, thank you. Just very briefly, I just wanted to mildly disagree with Oliver because he's not in the room, so it's safe to do so. Just talking about the one small thing that we could do. It's not bold, is it? Small things, we've been doing them for years. What I'd like to request on a personal level is, can we stop doing the small things that is reversing the really good stuff that's going on, but we can't fund it. You know, in Sheffield, we stopped funding community champions last month. You just hear about the programme of stuff they delivered, including identifying cancer at an early stage, which would not be picked up if it were just left to the system. No money, it's all wrapped up. So I'm going to say it every time, it's money, isn't it? And that needs us to be really bold.
Gavin.
Thanks. As Angela said, I did attend the Health and Wellbeing Board in Sheffield recently and was pose that question. Heard it all before. Put more politely than this. We heard it all before. What's going to be different this time? I think there are some things that are different. I think there's a growing view that the solutions to some of the challenges we face aren't in secondary care. We can't afford them. We can't staff them. We can't deliver them well. I think that's landed. I think also some of the system partnership arrangements that we've been developing will help us. I just wanted to say to Oliver in your introduction, just to thank you for the advocacy on our behalf in the conversations that you're having. But I do think there's something about financial incentives, but also the focus of operational planning that drives what I would describe as supply side solutions to our problems. And I think, in those conversations, I think there is an opportunity for there to be a shift and actually incentivize those things, which help to keep people out of secondary care.
Can see you've got a hand up on the screen as well, but if I may just come in on some of the points that have been raised and questions that have been asked as well. So I'm going to agree with Eleanor. Of course, I'm going to agree with Eleanor. Small things will be commendable, but this needs to be real big stuff. And I think we're not going to make a whole scale improvement or a shift. A shift itself requires big investment, yes, of resources, but of effort, I think is the question around that. And there are resources, they're in the system, they're tied in different places, and it's the bold things. It's not it's the small things to tag on will make a small difference, but it's the whole scale stuff to shift as well. And the councillor in the corner there, is it Councillor Baker Rogers? That Councillor Baker Rogers, the example that you shared there is exactly that pro-equity lens. So where a decision is made to provide something differently, then what's the pro-equity lens on that, so that somebody that can't afford a bus fare or somebody that doesn't have an access to transport is equally still able to get to whatever that things that could benefit it. So whatever the decisions are made that do need to be bold, big shift decisions, as well as the small things that can happen, what's that pro-equity lens that ensures that it's a just decision to be made for people too?
Thanks. I've got 3 more points. Firstly, Jason, who's online, and then David, and then Damien. Jason.
Hello. Yeah, for me, what I'd like to see is more work on children's obesity. If we stop children being obese, we stop adults being obese to a good extent. In my perfect world, I'd put a levy on fast food restaurants and take some money from them and use that to increase the prevention spend on childhood obesity. But if I was picking one thing for what I'd like to do, that would be it for me. Thanks.
David, and then Damien. You're all right. Damien?
Yeah, I'd probably side with Eleanor in the not one small thing. It's described as a complex system. It's a system. So if we're looking for shift, we need to look at where the leverage points are. And we were just talking about a couple of those just then in examples. I think that's a better tactic in terms of a plan of attack.
Oliver, can I hand back to you?
Yeah, please. Thanks. Damien took me by surprise. That was, I think, the shortest comment I've ever heard from Damien. So thank you, everybody, for keeping your remarks brief. But and that's me told, isn't it, about the one small thing. I think all I was saying was, and I don't disagree that we should obviously also.
Oliver, please don't encourage him.
I don't disagree that we should also shift the big things too. I think all I was saying is that if somebody wants to come back to me with the solution about how we shift the system in a big way, then I'm up for that as well. But in the absence of that, what are the small things that we can do differently? But I take the point that we've got to do both. And then on the bus pass point, anything's possible with money, and that's the challenge that we always face with the bus system. There just isn't enough revenue funding to go in there. If there was a way of doing that, working with partners who might be able to put some money in, and I don't know where the money would come from, then the system is there to enable that. I think it's just the money isn't there at the moment for us to do that. Certainly not through the MCA and the transport budgets that we have, which is one of the frustrations. And again, back to money. Anyway, I'm conscious of time, and we're already behind schedule on the agenda. But thank you for the reports and for the comments. Okay, in terms of next agenda item number 6, which is a focus on tobacco and how we are working differently. There's clearly a theme here. Can I just check how long you need, because we've got until 1 to 2. So in terms of questions versus presentation, how long do you need for the presentation, please, colleagues?
About 15 minutes, Oliver.
Perfect. Okay, so if we can try and keep that to 1:45, and I'll give you a little nudge at 1:45, and then we can have 15 minutes, 10 minutes for questions. That'd be brilliant. Okay, over to you.
Thank you, Oliver. Hi, I'm Sarah Hepworth. I'm a Health Improvement Principal and I lead on tobacco control for Sheffield and also for South Yorkshire as the Associate Director of our new South Yorkshire Tobacco Control Alliance, which I know you all know about because you endorsed it last November and we've been working, doing a lot of work since then. So we're here to update you on that today and some of the challenges. Do you want to introduce ourselves?
Oh, yeah, and I'm Leanne Sparks. I'm Senior Prevention Programme Manager for NHS South Yorkshire, and I'm going to talk to you about the QUIP programme.
Lisa?
I'm Lisa Wilkins. I'm a consultant in public health medicine at the ICB and the Prevention Programme Director, and I'm leaving the presentation to the other two, but I'll contribute to the discussion.
Thanks, Lisa. Next slide, please. So everybody in this room knows that tobacco continues to be, both globally, regionally and nationally, the biggest burden in terms of death and illness for us. We know that smokers die 10 to 20 years earlier, and before that, they live with illness for many, many years. We've been making significant progress in South Yorkshire, but we want to accelerate our efforts and go further. And that's why we've developed the Regional Alliance. We know that places that have done this before in the North East and Manchester and London absolutely have seen these results, and we want to follow suit. Next slide, please. So we contribute to all 4 of the ICP bold ambitions and just want to focus on the 4 points. Reducing secondhand exposure and having fewer parents smoking, because children model their parents' behaviour. We'll see fewer children start smoking. We will see reductions in infant mortality and save more babies' lives. We're going to accelerate those declines in smoking, and we're also going to reduce harm and reduce health inequality, as we've just heard why prevention is so important. We're going to put money back in the pockets of smokers, but we're also going to put money that's back into families' pockets that they can spend on other things, and money back into the local economy. We're going to improve the workforce across South Yorkshire, but also within our own organisations. So smoking is absolutely critical, but you'll see that we've put the smoking population, individuals and families at the heart of all of this, because that's critical to everything that we do. Okay, next slide, please.
Oh, and over to me. So yeah, as I mentioned, I'm here to talk to you about the QUIP programme. Fundamentally, what we're doing is embedding treatment of tobacco addiction in secondary care. But there are a number of strands that help us to do that. So if I'm just going to talk down them. Firstly, QUIP for patients. So we're ensuring patients are asked their smoking status on admission. This has led to us, as the slide says, to us screening over 240,000 admissions since the programme began. Our screening rate at the end of Q1 was 89%. So if we identify a smoker, they're then automatically referred to our QUIP teams who visit the patient to conduct what we call a specialist assessment. To date, we've conducted over 20,000 specialist assessments, and that's a really in-depth conversation with a specialist trained advisor who has been trained in motivational interviewing techniques to really kind of drill down on the core values of the individual and understand their motivations to quit. So through that route and through ongoing support with our community stop smoking service partners, we've recorded over 2,900 quits. And that's, as I say, patients who've been admitted to hospital previously. The second strand, QUIP for patients, as Sarah's already mentioned, we know that children from smoking families are more likely to smoke, and that to achieve our bold ambition, we really need to focus some activity on stopping the start. So we have an offer for parents and carers who smoke as well. Our adult acute trusts offer brief advice and signposting to community stop smoking services. Our children's hospital has embedded treatment of tobacco addiction, and they are the only children's hospital in the country to do that. Recently, they've worked with their pre-op teams to embed a parent carer screening question. And if a child who's coming into hospital lives with a smoker, our QUIP teams will make contact with them, offer support before admission or before their child's admission. The response to that offer has been incredible, and over at the last count, over 30% of people contacted have accepted a referral for ongoing support. So then I move on to QUIP for staff. Fundamentally, as I mentioned, the QUIP programme is a programme of culture change and shifting mindset around tobacco addiction, and therefore supporting staff who smoke is kind of at the forefront of what we're about. We've worked with occupational health and wellbeing teams to embed that staff offer across trusts, and to date have supported over 180 staff members to quit. More recently, again, we've partnered with our local authority colleagues to offer the Swap to Stop scheme to staff at SDH. It was promoted by Kirsten Major through her chief executive blog. Kirsten previously stopped smoking using a vape, so was obviously a great person to endorse it. And within 24 hours, the team had 60 members of staff email them asking for support. So it's you know, the demand from the staff group is absolutely there. And finally, just touching there on smoke-free hospitals, the QUIT teams really are at the forefront of embedding our smoke-free policies, particularly within our mental health teams, where we see the direct impact between the smoke-free policy and referrals to QUIT teams when they are properly embedded and kind of robustly enforced. So we've also just recently got all of our acute and mental health trusts signed up to the newly launched ASH smoke-free pledge, which is a real kind of achievement, and we're one of the first ICBs in the country to achieve that, so it's worth shouting about. Next slide, please. So I've talked about the numbers, but as always, the real impact is at an individual level. So let me introduce you to Alwyn, who received support from the QUIT team at Swift in Barnsley. Is the nervous moment where the technology.
Test, will it play for? Oh, it was looking promising here. Just no sound.
It's on speed, isn't it?
10 minutes. Things you get into.
Oh, it sounds
My name is Alwyn Harper. I live in Great Horton, which is near Baldry, South Yorkshire. So how bad you are. I smoke one every 5 to 10 minutes. Frustration of knowing I was smoking far too much and I couldn't get out of it. One of those things you get into when you think it's a good thing, or you actually come to the conclusion it is a bad thing. Been through so much, I thought I need a bit of heaven in a smoke every smoke. That was the only bit of heaven I got. I just knock on the door, we were trying to poke his head down, and he said, "Do you want to stop smoking?" Yes, please. Sounding courteous and kind, it's just what I needed. And I found myself responding to it. The stuff on the wall wouldn't have been here if he hadn't turned up that day. So I had been either dead or in jail for bankrupt. One of the two. There's no way I was going to get out of that. I'm a free man. I don't have to say that my bank account's pretty bad. I don't have to be wondering where my next meal's coming from. I wouldn't have done it on my own. I've tried. I get 2 weeks into it and start again. He made it forever. Thank you.
So that's Alwyn there, and a bit of a reminder about why we do what we do. So next slide, please, Mark. Okay. Have
they become hidden?
I don't know. Is it going to be on shared screen? Oh. Yeah, super. Okay, so we've recently been pulling together a business case for recurrent funding of the QUIT programme, and as part of that work, we've identified a number of wider, sometimes unintended positive impacts of QUIT. I'm not going to talk to them all, but just to highlight a couple. So firstly, tackling health inequalities. Data collected by our teams demonstrates that at each stage of our pathway, over 50% of the patient cohort is from IMD1. So we know we're reaching the population that is experiencing the greatest health inequalities. And similarly, we know that stopping smoking is the greatest thing we can do to impact, to have that wider impact on reducing health inequalities. Unobserved quits. So I've mentioned previously the 2,900 people who we've referred to Community Stop Smoking Service who've gone on to quit, but we know that the real figure is much higher. Evidence shows us that people attempt to self-supported quit after a brief intervention. And similarly, we know anecdotally of family and friends who've quit on the back of a loved one receiving support. What Alwyn doesn't mention in his video is that he lives with his brother who also went on to quit smoking as well. They live together and were very heavy smokers and now both smoke free. Repetitive nudges and messaging. Now, we know that people don't just decide to quit. They might think they've just decided to quit, but they don't. They've actually been nudged either consciously or subconsciously before they make the decision to make a quit attempt. So our team's been in the hospital sharing the same messages that they see across local and national media that you'll hear about, in addition to messages they might hear from primary care, really impacts at an individual level to push them towards those quit attempts. We know in our role as anchor institutes that the health and well-being of our employees is incredibly important. And as I've already mentioned, we've supported over 180 staff members to quit, which has had a massive positive impact on workforce productivity. And finally, in our discussions with kind of executive sponsors, Richard, who's quit SRO, and public health colleagues within the Trust, what's become very apparent is that our work through the QUIT programme and the wider Healthy Hospital programme has been a real catalyst for discussions around kind of prevention and health inequalities and that left shift that we've just been hearing about. We've heard reports of clinicians kind of actively seeking out our teams to find out what they can do within their service to reduce health inequalities, which is, of course, incredibly positive and powerful. Next slide, please. So as we've just been hearing about the discussion, we've talked about doing things differently and making that kind of prevention shift. And I just wanted to highlight how the QUIT, it feels like the QUIT programme really is doing this. So this work is prevention work at scale. All of our hospitals are delivering on the QUIT programme, a programme that is prevention focused work and a programme not delivered anywhere else in the country. It's truly system-wide work in there. We've got 25 partners in total. That's across the NHS, local authority, and the VCS. Incredibly complex. We still have issues, with data and sharing data and things like that, which I think is probably something that's worth discussing here as well. It's also been a huge programme of culture change, which is slow and hard work. We've shifted the thinking of secondary care from treatment to prevention in terms of tobacco control. And as I highlighted on the previous slide, it is really having that ripple effect and kind of prompting those discussions. It's delivered a focus on South Yorkshire. We received 4 MP nominations for parliamentary awards in the health equalities category, which in my opinion is the one that you really want to be nominated in, for this work at least. And NHSE colleagues have shared with us that we really are leading the way in terms of embedding tobacco control in secondary care. And finally, what the programme has delivered is an incredibly positive relationship with Yorkshire Cancer Research. The quote there is from their chief exec, but we've had subsequent discussions where they've shared their real keenness to work together with South Yorkshire in this prevention and health inequality space. And I'll pass back to my colleague, Sarah.
Thank you.
Hi, Sarah. Just in terms of time, we've got 10 minutes for the discussion. I'm conscious. Is this a long part of the presentation?
This is the chunky part.
Right. Can I be brief, because otherwise we're going to run out of time, and I do want people to have the chance to ask questions as well, please.
Okay. So in terms of Smoke-Free Starts, so Smoke-Free Starts is our overarching brand for the South Yorkshire partnership that we've developed. In terms of what we're doing differently, it's system level collaboration on tobacco control, strengthening and accelerating our focus on prevention, not just treatment. Each local authority and the ICB are independently funding tobacco control work on behalf of South Yorkshire for the first time. So we've collaborated lots, but this is the first time we're funding it individually. Also, we've got our sub-regional campaign. I'm just going to pass these around for people to have a look at. This is our smoking and mental health campaign. It's time to talk about mental health. We've reached over 450,000 people through various platforms, through TV, radio, social media on demand, and through our Stop Smoking services. Phase 2 is underway, and we've worked with King's College London and ASH. I led a conference this morning with ASH, a round table, to promote this work nationally, and we're gifting the sector the resources. No one else had done this in the country, so we're not just leading the way for South Yorkshire, we're leading the way across the country in this space. And it's really important because no one had tackled mental health and smoking and the impacts that can have on the benefits. We've developed our own Smoke Free Starts webpage, which is a platform essentially where people can go and get information about the stop smoking services and support that's available for them across South Yorkshire. But also we're building on that now and looking at the support at a population level around harm reduction. We're collaborating, and we have a Yorkshire and Humber mass media campaign that will go live in March of next year. And also we've expressed an interest for the National Smoking in Pregnancy Incentive Scheme, and we're going to be the first in the country to go on that as well. We're testing new approaches around incentives, and this is priority groups such as people living in social housing, those with mental health problems and substance misuse. We're also funding a world-class training programme for stop smoking advisors within West Yorkshire, Humber North Yorkshire and Sheffield and South Yorkshire. We're influencing national smoke-free policy and action, and we're involved in a variety of different workshops nationally with ASH and OHID, and that's around what else we can do to reduce and get to that 2030 smoke-free target. Our joint advocacy work that we've done, writing out to MPs, also nationally as part of the Smoke Free Coalition, around the tobacco and vapes bill has been really important, amplifying our collective voice. We've also been able to address the variation in nicotine replacement therapy and access to it, and we're developing a patient group directive. Luke, next slide, please. Luke is an example of a person who's come forward and used the stop smoking service in Sheffield, and he talks here in his case study about how, like Olwen, he wouldn't have been able to do it without the support of the service, and it was the Smoke Free Starts campaign that led him into that. It's improved his mental health, and he's actually got significant resource now to support his new baby. In terms of the barriers and challenges, local government funding was awarded to us. It came late in April, but all 4 local authorities were awarded it. We've got a 5-year quick date targets, and the money has to be spent by March. Sorry, can we move on to the next slide, please?
Sorry, I'm just going to have to give you another minute. I'm really sorry.
Okay, can we not take the time for discussion and move the discussion till the end?
There's not any kind of fat in the agenda.
In the agenda, is there not? Yeah. Right, okay. In terms of the barriers and challenges, I think the main barriers, just to say in summary, are that we've had 6 months to develop the programme and 6 months of bureaucracy to get through, and that's meant we've only got 6 months delivery, so it reduces the impact that we can have in terms of this work. We've not had any lead-in time. So we're having to individually fund our interventions rather than give the money to Rotherham, which is the lead authority on this in terms of being able to deliver the programme for us across the South Yorkshire. And then the final points, just to say, which are the barriers that are outlined on this slide, are really around the external funding and the legal governance processes make it incredibly difficult to get going. So we know what we need to do. We've got the right things in place, and we very much say yes in South Yorkshire, and then we look at how we get it done. But that's been the barrier really in terms of going forward.
Thank you. And I'm sorry to cut you short. It's just I want people to be able to have the chance to ask questions. You've got 5 minutes for questions. Piers, would you mind just taking questions from the floor?
Yeah, of course.
Thank
Any
you.
questions?
Sorry, can we move on to the next slide, please? And the next one. Yeah, that's the question.
Back a slide, Mags. That's it.
Piers, over to you.
Yeah, thank you for the presentation. So I guess the stat that's in the ICP strategy that will be held to account for is reducing smoking in the population to 5% by 2030. So obviously the list of recommendations you've got, will they be sufficient to do that, or is there wider multi-agency action that's required?
David?
Certainly a change in legislation would go some way to making inroads to that. So I suppose we are expecting the smoke-free bill to go through Parliament still. So that's one thing, Phil, that I think we've all supported across all of our organisations in South Yorkshire.
Christine and Angela. Christine.
Hi, thanks for the presentation. Christine Joyam, Chief People Officer at the ICB. I guess I think this is a challenge to us as an integrated care partnership. We stated joint commitments, and one of those is about how we use our collective resources. So I feel this is a real ask of us. How do we deploy our joint commitments around resources to sustainably fund this work so that we can keep doing the work that we said we needed to do?
Angela.
Just very quickly, thank you so much for the presentation, and also for what you've not presented that I have heard previously, a part of it. I was just wondering whether there is any prevention as well in there, because again, this is super important and is something that we need to do. However, how do we prevent people? And I know that the new legislation will have an impact, but for example, you just have to walk down Fargate and stop outside one of the vaping shops to see them selling vapes that are marketed for young children because of their color. I mean, I've taken a picture just on the way here, and I'm going to refer them to trading standards when I have a minute. Yes, having the adults stopping smoking is brilliant because then they have an influence. However, we're also working against marketing that is heavily geared towards encouraging kids to vape that will lead that. There is a lot of vape is brilliant for people who want to smoke, but they also, you know, they're very clever, aren't they, in the way they market it, so that you see young girls in particular with this really colourful and funky kind of
There's two things that are going to make the difference there. We need the tobacco and vapes bill to be implemented, because that's where we're going to get those restrictions on advertising, where we're going to have plain packs. That's what we need, but they'll be behind closed doors. But we also need investment, both in the workforce of trading standards across South Yorkshire, but within the delivery, because if we don't have that delivery across the board, we're not going to be able to tackle the problem effectively. We've got far more demand than we can deal with, as you've rightly said. And actually, we developed the vaping resources for children and young people. We're doing the education in schools, but that's a tiny drop in the ocean. When we tell children not to do something, we know it's ineffective, unfortunately. It's important to get the facts straight, which is what we do, but legislation is what we need, plus that investment in trading standards. And we do have investment in trading standards across the region, but it's not sufficient to deal with the demand that is there. So that is one thing that would make the absolute difference across South Yorkshire, for us to put some investment in terms of prevention into trading standards.
Thank you. Any further questions?
Oliver, you asked what else we could be doing, and Piers asked what more could we be doing. So obviously we've got the regional and South Yorkshire campaigns going on, so every organisation can help to contribute the spread of those messages and reinforce it, and likewise ensure that everybody's organisational staff understand the importance and are able to provide brief advice and to signpost people to where they can get support to stop smoking. And we've had a really big focus on the secondary care angle, and the trusts have done terrifically to get the QUIT programme off the ground, particularly seeing we started it just as the COVID outbreak started. So I think now we need to have a greater focus on community services and primary care around how they can support people to stop smoking as well.
Sure.
So, in the context of being bold, could we not make our parks, or at least playgrounds and the areas around them, smoke-free zones, even if we can't enforce it by law?
Yes. In Sheffield, we have got smoke-free playgrounds, and it is something we can extend to other areas, and that it's taken the learning from each of the areas, and we've all got different bits that we're specialising in, and we're trying to look at that across South Yorkshire. So this is part of what the Tobacco Alliance will take forward for South Yorkshire. And it's also revisiting the smoke-free policies that we've got in place within our institutions, because they're never a done deal. You know, we've always got visitors coming in, and you know, the mental health settings are really challenging, as well as the pregnancy settings. So yeah, it's a constant review.
Can I just add one thing before we finish, which is you mentioned the NHS Parliamentary Awards. They got shortlisted, as they say, and unfortunately they didn't win this week. We was robbed, I think was the conversation you had with me, Richard. But it's a great tribute to a really innovative piece of work. And you know, I came from outside the area. This is a really innovative piece of work, trying to work with individuals in a very different way to get them to give up smoking. I think it's a great piece of work. Thank you very much. Oliver, can I hand back to you?
Thank you very much, and thank you guys for running through that quickly. Appreciate that. Handing over to Ruth and Nigel and Gail. This is a focus on physical activity and how we can work together differently to increase physical activity through things like active travel and reframing our active transport approach. So can I hand over, Ruth? How long do you guys need for the presentation versus how much time can we leave for comments and questions?
About 15 minutes.
Perfect.
If
Okay.
you talk fast.
Okay, so sort of roughly 12 minutes past. So I'll give you a little nudge.
Okay, thank you. So my name is Reece Spear. I'm a consultant in public health. I'm based within SIMCA, but joint funded post with the ICB. I'm going to just talk a little bit about physical activity and why that's really important to the prevention agenda. And I'm going to hand over to Nigel and Gail from Yorkshire Sport Foundation, who are going to talk a little bit about the work that's already happening in all of our 4 places and how we're working collectively across those 4 places and those 4 place leads to see what we can do additional to add value to that South Yorkshire level. So why physical activity? Well, I'm going to quote from Dame Sally Davis's Chief Medical Officer report of 2019. If physical activity were a drug, we refer to it as a miracle cure due to the great many illnesses it can prevent and help treat. And that's very, very true, but I think it's fair to say that we don't really recognise the important role of physical activity as much as we should. Next slide, please. And then what do we mean by physical activity? It doesn't have to be a strenuous session in the gym or kind of regular sporting activity. There's lots of little different ways that we can be physically active. And I think these 2 infographics are really helpful. The one on the left of the screen is from Public Health England, which talks about active living. So how do you build in physical activity to your daily lives? You know, are you taking the stairs? Are you making sure you're standing up and walking around at regular intervals? And then this one from Cancer Research UK on the right, which also kind of gives lots of other examples. So it could be walking, gardening, dancing, playing with the kids or the grandkids. And I think one of the central messages is it doesn't have to hurt and it can be fun. And doing a little bit of physical activity is really important. You know, it doesn't matter if it's just a little bit, it's better than doing none at all. And we know in South Yorkshire that about just sort of under 2/3 of our residents are meeting the physical activity guidance, but that's not all of us are. And about 1 in 4 are physically inactive, which means they do less than 30 minutes of activity a week. So, next slide, please. And this matters because low physical activity levels are a massive issue if we're trying to improve health outcomes for our population, as are the differences in levels of physical activity between groups and neighbourhoods within our population if we're trying to reduce health inequalities. So not only does regular physical activity reduce the risk of developing health conditions, and that includes type 2 diabetes, cardiovascular disease, dementia, breast and colon cancer, but it also helps in the management of health conditions, keeping people well and improving their quality of life and improving their outcomes. And then there are additional benefits as well. It supports mental and physical well-being, supports social inclusion, and helps maintain independence and reduces the risk of falls, particularly in older people. Next slide, please. So increasing levels of physical activity and also helping those who are physically inactive to be a little bit more physically active also supports our bold ambitions. Obviously, it does link to the prevention of ill health and managing health conditions, but it also Physical activity in children helps their social development, their physical and mental development, helps them to be ready for school. It supports workforce well-being, not just for the health and care workforce, but for our wider population. And it also supports social inclusion, confidence and skills. And improving physical activity in those population groups and neighbourhoods that are physically inactive is a key way to help us reduce health inequalities. Next slide, please. And what I think is worth bringing to the attention of this group in particular is that health professionals are really like trusted, important source of physical activity for people. So when people get a long-term condition, they naturally turn to the healthcare system to get some guidance about what they can do physically active that's not going to worsen their health condition and perhaps improve their outcomes. Next slide, please. And then this is just a bit of an overview of some practical ways where physical activity can make a difference. And there are some fantastic examples of this happening in all 4 of our places. So there's some more individually focused interventions around referral schemes for people with health conditions, how we build it into social care and healthcare pathways, how we can support people get ready for surgery and so that they're reducing their risk of complications. There's also helping our health and care workforce have the skills so they can help and advise people around physical activity. But it's also about how we make it easier for people to be active. So safer streets, walkable neighbourhoods, accessible green spaces and parks, active workplaces and greater travel choices around making it easier for people to walk, wheel and cycle. And that's core to our emerging active travel strategy that is being developed with all 4 places, which we're going to bring back to a later meeting to talk in more detail. And now I'm going to hand over to Nigel and Gail. We're going to talk about some in more detail about what's already happening and how we're trying to build on that.
Thank you, Ruth. I'm Nigel Harrison, Chief Executive of Yorkshire Sport Foundation. I just want to spend a couple of minutes on the structures and how the strategy are lining up across South Yorkshire, just give an explanation of what's going on. We start off with the principle that the solutions for supporting more people to be active are rooted in our communities. And it's our community who know best how to get people active. So we kind of try to have a focused approach on communities across South Yorkshire. I'm using that as an example of Active Burngreave. It could be anywhere, but we started there about 5 or 6 years ago, actually, with the Deputy Mayor of Sheffield, Councillor Saheed was our community champion at the time. Has done some fantastic work in Burngreave area, using sport and physical activity as a vehicle, not just to get people active, but also to help with other social outcomes as well. Some fantastic work on that. And we've learned a heck of a lot about community development through that programme and how to embed physical activity and sport actually in that community. But it can't just be there. If we're going to take a systems approach to physical activity and sport, then we need to then look across the district. And okay, we're zooming out there to Sheffield. So obviously Burngreave has to sit within the community support and the strategy and the policy and the systems that are coming across Sheffield. And in Sheffield, the strategy there is the Move More strategy, overseen by a multi-agency board of the National Centre for Exercise, Sport and Medicine, and there's fantastic innovative work taking place there, but there's no overarching strategy there. And the main thing to pull out there is multi-agency, and it is a whole system approach to physical activity that we're I'll say attempting to achieve across Sheffield, and that's been going for a number of years. And then when we zoom out again, thank you, that sits within the context of South Yorkshire. And how can the systems that take place within SIMCA and the ICS and the discussion we're taking place actually is a question we've been asking all along today, is how can we add value to what's happening there? So just take us into a little bit more explanation of that. Thank you for the next slide. So
taken on board inequalities, and all the physical activity stats will all line up with deprivation statistics, like many other issues are. We've worked with local partners to actually try to identify which areas do we really need to focus on across West Yorkshire and take that community development approach there. We think we've got around, well, we know we said we've got 42% of those areas which have resources in place where we can do something in terms of that. There's some professional officer support, community champions, some spending money in there, and that's come from various resources, sometimes from Sport England. We used, actually, Burngreave was Comic Relief. We've used Kofi Regenerate, anywhere we can find funding to try to get that approach in those areas. There's been a big programme in the Dearne Valley, for example, which we've been part of, and the 3 local authorities involved in that around Dennerby, Conisbury, etc. So it's that real community development, and we want to fill that map up with resources basically, and learn and share and really do that. And then at district level, thank you for the next slide. We've got the equivalents of Move More in each of them, and they've been going now a number of years. Firstly, there's a strategy in place for each of the districts, and then there's a multi-agency group and a multi-agency network trying to put in place that systems approach we do. Now, Get Doncaster Moving as being one of the 12 local delivery pilots of Sport England for the last 5 years. It's moving on now to be a place-based partnership across the country. And there's a huge amount of learning and a significant amount of funding that's gone into Doncaster over the last 5 years. And there's some superb work taking place there. But it's not the only place. The other 3 haven't just been sat back doing nothing whilst watching on Doncaster. The others have been there and actually been operating for a while as well. The good news is each of the other 3 have been identified by Sport England in the next phase of place-based partnership. We're in a really strong position in South Yorkshire. There are going to be 80 places around the country, and we've got all 4 now of ours as place-based partnerships, which will give us a real solid foundation from which to work on as we go forward. Which is we're all celebrating a bit on that when we go on that, because that gives us something solid to go from on that. The Rotherham plan literally was submitted yesterday as an initial phase. Barnsley was submitted about a month ago, and we're expecting the answer of yes, here's your money soon. And the Sheffield have already got some transition funding there. So we're quite excited we're in there. So the next question then is the South Yorkshire level. And it's, sorry, just to say in Doncaster, just on this side, just saying Doncaster. Yeah, thank you. Can you just go on to that? That next slide is the Doncaster strategy, and just reinforces really the systems approach that Ruth was talking about earlier on, using the 8 interventions that ISPA, the International Society of Physical Activity and Health, put forward. It's about green space and blue sites. It's about schools. It's about having easy places within which you can walk and travel around. It's around having good, strong community organisations. ISPA have come up with that, but we've done it for years, got people in the room saying, what would you need to get more people active? And we always come up with the same stuff. It is about green and blue space. It is about being able to walk around, and it is about strong schools and so on. We know the answers. It's about actually in a place how all that comes together. So then, thank you. Next slide. The South Yorkshire question is, it's fair to say we've taken a very district approach, and certainly as an organisation, that's how we support. We have managers in each district, etc., supporting what's taking place. But actually asking ourselves now, where's the added value for South Yorkshire that comes in and working together? We've done learning and sharing for a number of years, but actually what more can be done? I'll just pass on to Gail now, who's just explained some of the conversations and work that's taking place. So.
Thanks, Nigel. Yeah, I think Nigel's covered it really there. We know that there's great work going on across the 4 districts now around sport and physical activity, and has been for quite some time. Where we haven't been able to add that extra bit of focus is around that South Yorkshire footprint. So now we're looking at, as you described really well earlier, Rachel, around that kind of where does working at that kind of South Yorkshire footprint add the value. So we've had some initial conversations with the 4 local authority physical activity leads, some of our colleagues from SIMCA and ICB, and Daniel's in the room and he's been involved too. And what we're really trying not to do is recreate the wheel. We're not trying to create any extra groups. We're trying to understand what does the South Yorkshire work look like at this level, and around some of these priorities that we're starting to develop, where do they plug in best and where could we support some of that development? So I'm hearing strongly from conversations I've had so far that extra groups are not needed and are not really the way forward. But what we're trying to do is to articulate what we think is important using our experience of working with physical activity in the 4 places so well for so long, and then trying to kind of elevate that to, okay, so what does this look like at a South Yorkshire level, plugging into some of the things that are already in development or happening already. And to support that, we've had a successful meeting, initial meeting between Oliver already with the Chief Exec of Sport England, Tim, where they kind of had a chat about some of their emerging priorities and some of their interests, which clearly overlaid with some of our early conversations too. So that'll be the next step, is trying to kind of build a narrative a bit more about what some of our bold ideas might be about taking that forward, and where we could plug those ideas into. Thank you, Chair.
Thank you, and thank you for keeping to time. Appreciate that. Okay, we've got time for questions. Stephen, I don't know if you, because obviously you've been involved in some of these conversations behind the scenes, like I have, and a really good meeting with Tim. Actually, I thought that was brilliant, and a really good conversation about, like you say, where those overlaps are, which I think are many and plentiful. But Stephen, did you want to just add anything to that conversation, just about the context from the MCA perspective?
Yes. So, I mean, what I would say is thank you to Gail and Nigel for being here and sort of continuing the conversation that I think was kicked off between yourself and Tim Hollingsworth. I think the subtext of the slide deck here is above and beyond actually the immense importance of this in terms of our agenda. Is there is an offer in the room at a South Yorkshire wide level from Sport England to come and work with us, which is additional to the work we're doing within the individual local authorities. And I think actually what we should do following today is to sort of take that offer away, and then we should start working that up into a firm proposition that we can bring back here probably in the coming months. Actually, that would be my plea, because I think there's something very tangible here, which is additional to the existing stuff, which adds massively into the stuff that we've talked about on this agenda, but in the wider context of our work. That's what I would say. Thank you. Piers, can I hand over to you, please?
Any other points people want to raise?
Right. I think you made a really good point at the start by saying how much exercise can do to contribute to someone's being and health, and how much trust people put in their doctors. So could a doctor not put on the prescription not just the tablets, but something like one 20-minute walk per day, go and do park run, that sort of thing? Because I think if you've got your trusted professional saying this is what you should do you not think that might give that person that little bit more of a push to actually go out and do that 20-minute walk?
So that's a number of points. So thank you. Nice to see you again, Nigel, from last week. I've always been an advocate for this. Actually, I was one of the co-chairs of the Get Doncaster Moving Body in a past life, and we're talking about causes of the causes. And if we're really going to tackle things like the obesity challenge we've got ahead of us, this is one of the tools that's more likely to be beneficial than some, skinny jab that's marketed by a pharmaceutical company. This is a life-changing behavior for some people that will make us much close to giving up smoking. This is up there with that. Just to pick up your point about exercise on prescription, that's what we used to call it. I'm a GP by background as well as a chief medical officer, so we do have schemes like that have existed and continue, and actually we have a lot of general practice accredited for park run practice. So there's an initiative run by the Royal College, so I guess there's more we can do on that, but they do exist. Thank you.
First of all, Josie, thank you for the presentation. Really excellent, and I really love the work that you're taking forward. For me, I'd be really interested to know what else you could do in terms of people with a disability and autistic people and people experiencing mental health. Because I'm thinking in terms of the presentation around smoking and public health and there's a real common ground about where we're trying to tackle inequalities. How are we also thinking about those who are often the most deprived and those who are often the most affected? So I'd be really interested to see what other connections can be made, both in terms of people with a disability and also in areas where there is real inequality.
Actually, I think Alexis just made my point really, which is about could we look at this through a health inequalities lens? But my second point was just I thought Stephen's proposition was a really good one. I'd be really interested in contributing to that.
I think it's really important as well to think about our workforce. We have a lot of people just sat down all day at machines and drivers driving. I think it's not to miss them out of everything that we're doing in this board.
Marianne.
I was just thinking about connecting it back to what we heard a bit earlier around the QUIP programme and the kind of prevention at scale type approach, and whether there's some learning in terms of thinking of the multi-agency partner scale approach, and whether we could think about physical activity in that way, the kind of making every contact count, and what can we do together at scale, because that really fits, doesn't it, with the South Yorkshire added value component as well.
Thanks, Chad. I was really pleased that you put the Doncaster slides on, just from the Doncaster perspective as well. You used our circle on there, which had all of our grade 8, so really wanted to have different ideas and different approaches, and absolutely that pro-equity lens in picking the areas of Doncaster that are the more deprived neighbourhoods. For each of those areas, the ambition to improve was probably the same at the beginning, but actually the flexibility of the small team and the much larger network working on each of those had to be really flexible. So really going where the energy is and tracking that persistence on each of those areas. So those 8 that you had on the screen, some of them have been more successful, some of them have needed more of a push, some of them have had to be actually that bit of the system's not ready yet, and workplace for Doncaster is probably one of those. So picking through, though, there's probably some of that, what can we do at South Yorkshire level that we've not done at place level? What's the thing that we can add the extra value to? There's probably some from that wee circle that we could pick out and promote for South Yorkshire too.
Angela.
Just very quickly, I think it's great to have an overall approach, because so that we can all look at what works and what doesn't work. But I think language is very important, because people who are inactive, if you say active travel, people think you've got to cycle, or and if you live in Sheffield, the first thing that people will say is, oh, it's really hilly, it's really difficult. And actually the word active psychologically, or sport, it kind of shuts people down and say, I can't do this because, one, I haven't got time, two, I'm not fit enough. So I like the language, the move, and I think we have to use that more, and maybe get away with from the word active in sport as well, because if you tell me be active, I'm not going to do anything.
That was noted, Angela. Thank you. Can I just say, I think the bit we're going to finish on is what you said, Stephen. There's clearly a conversation that says what, in addition to what's going on in each of the local authorities, which is substantial and impressive, what could we do? What should we do to talk to Sport England? What can we do at a South Yorkshire level that would add on top of that? And I think that's a bit of work we need to do outside. And I think that's really helpful. Thank you very much. That was a great presentation. And nice to meet you, by the way, because I've met you before. Oliver, can I hand back to you?
Brill. Thank you very much. And we will definitely follow up on that. I know I'm going to have another meeting with Tim, and we'll carry on working with Nigel and Gail. But thank you guys for the presentation. Right, we're on to cardiovascular disease prevention, and working differently to enhance the prevention of CVD, including community case findings, working with community pharmacies and health checks. Daniel, I believe you're going to take us through the presentation. We've got till 3 if we need it. How long do you want for the actual presentation part of your section?
Fine with 10 minutes for the presentation, then we can have a general discussion as to what we've heard.
Perfect. Okay, brilliant.
So, hi everyone, it's lovely to meet you all. I'm Danny Fitzgerald and I work for NHS South Yorkshire. So we've heard around smoking cessation and physical activity and why they're so important. Both contribute to reducing cardiovascular risk, and I'm going to talk today about South Yorkshire and cardiovascular disease prevention. So when we talk about health inequalities, and just going back as well around CVD and cardiovascular disease, it's an umbrella term for conditions that affect your heart circulation. So these include high blood pressure, heart attacks, strokes, and vascular dementia. But cardiovascular disease causes a quarter of all deaths in the UK, and it's the largest cause of premature mortality in deprived areas. In England, between 2020 and 2022, people living in the most deprived 10% are twice as likely to die aged under 75 from all circulatory diseases than people living in the least deprived 10%. Looking at the last available data, next slide, from 2020 to 2021, in South Yorkshire, men from our most deprived areas are dying 8.7 years earlier than men in the least. And circulatory diseases are the largest cause of this gap for men. Looking at women in the most deprived areas, they're dying 7.6 years earlier than those in the least deprived, where circulatory disease is the second largest cause, 0.5% behind cancer. Next slide. We're seeing, after decades of reduction, mortality rates for people aged under 75 from CVD in South Yorkshire are now increasing rapidly, which is unprecedented. This increase is greatest in Barnsley, Rotherham and Doncaster, and is much higher than the slight increase in the England average, which is the grey line at the bottom. And although Sheffield has not seen the rate of increase of the other areas, it remains above the national average. So connecting back to our bold ambitions and looking at child development in early years, we know that encouraging parents to make healthier life choices will improve child development. And we're seeing this increase will have an increase in levels of parental death, causing significant childhood trauma. So to strengthen and accelerate our focus on prevention, we need to act on CVD, because as I mentioned earlier, it's the largest cause of people dying early in our deprived areas. CVD prevention is also essential for economic participation, as it's the greatest risk of leaving the labour market with someone with the onset of CVD having a 22% likelihood of leaving their job, whilst 1 in 3 people, working age people who are already economically inactive, have a heart, blood pressure or circulatory condition. And wider costs related to CVD to the economy are estimated at £15.8 billion annually. Then looking at how we value and support our workforce, just talking about health and care, we employ over 48,000 staff in South Yorkshire. These are our residents, and as anchor networks, we have a responsibility to support their cardiovascular health. But we have an opportunity, because most cases of CVD can be prevented through population-based interventions and individual lifestyle changes. So next slide. The long-term plan from 2019 said that CVD is the biggest area for potential life-saving changes in the next 10 years. Next slide. So high blood pressure and cholesterol are the 2 leading clinical risk factors for cardiovascular disease. This graph shows a timeline in the number of people with high blood pressure being treated at the blood pressure level. It shows a drop almost over COVID and our progress recovering to pre-pandemic levels. So since September 2023, our improvement from 70 to 72% is estimated to have saved 24 heart attacks and 36 strokes. But if we were to reach 80% in the next 2 years, we'd prevent 119 heart attacks, 177 strokes, 95 deaths, saving up to £3.4 million. Next slide. As for cholesterol, the graph shows the number of people who already have cardiovascular disease who are on a cholesterol lowering therapy. Since 2023, our improvement from 85 to 87% is estimated to have saved 72 cardiovascular events and 10 deaths. But if we were to reach 95% in the next 2 years, we'd prevent 413 cardiovascular events and 50 deaths. So next slide. So in NHS South Yorkshire, we're leading a programme of work to improve cardiovascular disease prevention. Firstly, through a relentless focus on health inequalities by understanding and designing targeted interventions to address inequalities. Secondly, reducing the drop-off at every stage of a patient journey so that more people are aware of CVD and then treated in the most effective way. And lastly, around maximising our clinical engagement by having standard clinical guidelines and greater clinical leadership. Next slide. So to give some examples so far, we have worked with the North Eastern Yorkshire Analytics team to use data differently to provide targeted support to practices and communities at accelerating prevention and tackling health inequalities. 7 dashboards on clinical risk factor performance were created, which look at regional ICB place and practice performance over time, whilst looking at deprivation and ethnicity. This data helped our clinical leads provide one-to-one support to practices, and one practice from an area of high deprivation improved their blood pressure management by 15% in 1 year. Next slide. We're also working differently to utilise capacity outside of general practice through collaborative community projects with local authority and the voluntary sector. These include the How's the Ticker programme, which won a local government award, association award, and has seen over 7,000 people and identified 2,800 people with high blood pressure readings. We've been raising awareness of cardiovascular disease throughout Know Your Numbers Week in September and working with community pharmacy to deliver blood pressure checks out in the community. We're also utilising the new independent prescribers within community pharmacy to improve hypertension and cholesterol management. Next slide. And then in having a relentless focus on health inequalities, we've created a targeted primary care incentive scheme focusing on primary care networks with the highest health inequalities in cholesterol treatment. It incentivises patients from the 20% most deprived communities nationally being treated to recommended cholesterol levels. And between June 2023 and March 2024, we saw overall treatment to target levels increase by 6%, whilst our index of slope index of inequality also improved by 2.5%. Then this slide shows how we, the Integrated Care Partnership, currently work together on cardiovascular disease prevention. So through the improvement of modifiable risk factors such as healthy weight, smoking cessation, physical activity, and commercial determinants of health, all things we've heard of today. Moving on to how we increase the testing, management, and treatment of clinical risk factors through health checks and community outreach. We can also support the health of our workforce in our role as anchor organisations and local businesses. So to summarise, together we can prevent most cases of cardiovascular disease, but we all need to work together to be more than the sum of our collective parts. It's the next slide. So thinking about what we've heard and discussed today on prevention, smoking cessation, physical activity, and cardiovascular disease prevention, do you have any final thoughts on what more we can do differently and collectively to overcome these challenges?
Daniel, thank you.
Thanks. Piers, just please feel free to kind of manage the discussion.
I'll lead the discussion in here. Is that all right, Oliver?
Thank you.
Angela.
Oops. Yes, thank you so much for the presentation. The graphs are very clear. Sorry, I have had to print things because I can't see things on screen. I was just wondering whether the data also looks at how we know that certain ethnic groups are more kind of genetically prone to certain diseases, and what the percentage of the people that we save in inverted commas is targeted to include those groups that are most at risk of certain, not just in this case cardiovascular disease, but whether we can tell whether the people that we saved are all white, for example, or whether we actually having an impact on those people that we know are more impacted by inequalities and health inequalities in particular.
So on that, the data around the kind of size of the prize for the hypertension and cholesterol, that doesn't look at the ethnicity of the person saved in inverted commas. But the data that we've worked on with North Eastern Yorkshire Analytics team does look at ethnicity, and whilst it's not a perfect data source, we can use it to kind of target interventions. And we were actually working with the National Behavioural Science team around how do we improve the quality of the messaging for people from Black and ethnic minority communities around home blood pressure monitors, so that actually we are being more effective in that communication. So that is something that we've been doing over the last year.
Yeah, I completely agree with the whole community approach. I'm a provider out in the community. I think there's definitely something around the VCSE. I particularly work around carers, and I think there's a lot around all of the initiatives, the smoking, the physical activity and this, and it's around them having time to actually come. So the fact that if there are home monitors, if there are groups that they're accessing, I think pharmacies are great, but it's trying to reach those people that that probably are the people that need the support the most, but don't physically have the time because they're caring for somebody else. So it's just how creative we can be with reaching those people and using the community groups. You know, I'm part of the BCSE Alliance. We're wanting to work together more. So talk to us, see what we can do and how we can reach these groups.
Yeah, absolutely. And we did also work with Yorkshire Sport and with the Health Innovation Network around doing a project within Doncaster around a active lives kind of pilot with mothers and how we integrated cardiovascular disease prevention into kind of a physical activity group environment. So that was a really good project. And I think that the key to this as well is, as you mentioned, it's about making every contact count around where the contacts are being had, how we make the most of those. So we worked with the local maternity and neonatal system around home blood pressure monitors being available in maternity services because of it being a huge risk around childbirth. So that's another example of where we've been able to invest as NHS South Yorkshire and bid for separate funding to maximise that kind of making of a contact count. But granted, we need to do it better and more.
I think it's following it up as well. So it's great that they're identified and they're having that blood pressure check, but it's following it up. Yes, it's high. What are we going to do about it? Are they still attending the appointments? Are they able to get to the appointments? You know, a lot of the time with doctors' appointments, you're in a very tight window, and for whatever reason, say the cared for person has wandered or they've had an episode, and then they're late for the appointment, they miss it. It's then making the effort for them to go back and following it up when their care is actually secondary. That's my worry.
So I just wanted to pull out that this was one of the first areas we identified in the ICB where we sort of targeted differential investment. So we specifically looked at areas. We didn't have a global sort of response to, cardiovascular disease, which affects all of us, but it affects some people more than others. And, Daniel's one of the team who sits in the medical directorate. So we purposely put the money to the areas where we thought, needed the attention because we've got a small resource of teams. So it was just to pull that out. It's talking about when we're going to be bold and do things differently. This is kind of what we're asking. We're talking about maybe doing it on a larger scale, but we're already doing it in some of the work streams. And I know the team are nodding over there. So other elements that we've heard today are taking that same approach.
Thank you. Thanks, Daniel. I was just wondering, I think when we come to our next integrated care partnership, we're going to have a look at bold ambition number 4. And I really like how you've looked at that in the context of your work. And I think if we look at our entire workforce, paid and unpaid, so not just the employed people, that would include carers. So we'd be looking at over 300,000 people. And as part of the development of that work, we are thinking about prevention. So it would be really great to join these pieces of work up more effectively. So because there's no point doing the same work, is it duplicate work? We can do the same work, but just expand it. So it'd be great to have that conversation.
Yeah, thank you. I just wanted to make a comment building on what Kate had said about the voluntary sector and linking with communities. And similarly, Christine, about prevention. What I noticed thank you, Daniel, by the way, great presentation. What I saw when you put up the charts was CVD is the biggest killer, and then cancer, then respiratory disease, then gastro disease. CVD is caused by high blood pressure and cholesterol, all of which are caused by smoking, poor diet, lack of exercise and alcohol. And the solutions to those things in our poorest communities, or the people who suffer the worst of the inequalities, are in communities. So I'm not sure what I'm saying really. I just want to flag up that connection with communities, because getting a blood pressure monitor to somebody does not solve their high blood pressure problem or stop them going into hospital with a heart attack. And the other thing is that people now, I think certainly in Sheffield, we are more multimorbid than unimorbid. So people don't just have cardiovascular disease, they have 3 or 4 or 5 different things. And improving the lives that they live will be through the communities that they live in. So thank you. And I feel I'm being negative. I will see something a bit bigger and non-specific.
No, I do agree. And I take your comment. I think it comes back to that kind of what is the sum of our collective parts, and that modifiable risk factor being, a really big rectangle as part of that kind of 4. So yeah, absolutely, it does connect to all of the things that we've discussed today.
And the other one that was common on your slides, thank you, and the other ones that we've seen today is around the commercial determinants of health as well. So would be one of those big hitters, I think, and one of those things that we can do at South Yorkshire level more and better that we can do at local level. So not things that are anti-business, but things that are anti-harm to health. There are significant things that we can do as a South Yorkshire level, significant things that are decisions made or even to be considered about what's the right time and how that will make an impact on all of the things that we've heard about today.
No points. Oliver, can I hand back to you?
Thank you. Appreciate that. Okay, we've got a little bit of time in the diary, in the agenda back. So this item was supposed to go through till 3, so we've got a little bit of time, but now is the comfort break, unless anybody's got anything else they'd like to add in just at this point in time. But could we maybe then take 15 minutes now and come back at 10 to, and therefore kind of we'll gain a little bit of time back. But if people could just take 15 minutes and be ready at 10 to be back for the conversation.
I will order them in 15 minutes.
Wonderful. Thank you very much.
Right, we're back in. Oliver, can I hand back to you?
Please do. Thank you. Just get my notes up. Thanks, everyone. Okay, next item on the agenda, item number 9, is collaborating across South Yorkshire to work with and involve citizens. And this is about providing an update on the Refresh Start with People Integrated Care Board Citizens Involvement Strategy. And the work that's happening across the system on the back of the refresh of the strategy. And I think, Katie, you're going to take us through that.
Yeah, thank you. So I'm Katie Davison, Deputy Director of Involvement for the ICB. I think most of you probably met me because I did come a few months ago to talk about this. So I'm just bringing a bit of an update. Next slide, please, Mag. Okay, so as I said, I brought it a few months ago. When I came, I was talking about the fact that the ICB was updating our citizen involvement strategy, which is our Start with People strategy, and that we were starting an involvement approach to the refresh. We took a 6-month involvement update process, and we included, which I think is key for this meeting, a co-design approach with many of your colleagues from your organisations, and then the strategy was signed off by our board in May, and we're now on with its implementation. So obviously I wanted to come back and just keep the ICP cited on that. However, I'm not going to go into lots of detail about the ICB strategy because it is just an ICB strategy. The board paper was attached to the papers if you want more detail, and I'm happy to answer questions about that as well. What I've tried to focus on today is the bits that I thought the ICP might be the most interested in, which was mostly some of the key themes that our work with citizens about how they wanted us to involve them in our work, what they said to us and how we thought that might read across to the ICP. So as you can see from the slide, we've grouped them into themes. So the first theme being availability and decision makers in the room, and that references our citizens being able to talk to you guys. The second theme was about the lack of visibility that what people tells us makes a difference, and that's always the biggest theme that comes up when you involve citizens on anything, to be totally honest with you. Then there was the ongoing insight and dialogue, not one-off conversations. They wanted us to be accountable and open and honest. They wanted us to value lived experience, work with people that our communities trust, recognise that not everyone is digitally enabled, and invest in involvement. So those key themes. Next slide, please, Max. So what the ICP Ops group has done is have a look at those themes and start to think about how they read across into the ICP. This is just the Ops group's thoughts, so we very much welcome the board's views on those. So if I just take you through some of the things that we thought. So the availability and the decision makers in the room, we thought actually that probably was slightly less relevant to the ICP because obviously there's a number of councillors in the room who will have direct links to their citizens, a number of voluntary sector organisations, and obviously the chair himself. So we thought we were probably doing slightly better with that one, but Fran from Health Watch did make a challenge. Oliver, she was hoping that you might be willing to come back to some of the communities and hear some of the feedback yourself or other execs in the room as well. So that was one of the thoughts that Fran had that we might be able to do to sort of strengthen our approach in that way. In terms of lack of visibility and showing people that we're making a difference, that reads across very nicely to the ICP development work that's happened that Mariana will be talking about later. So without wanting to steal Mariana's thunder, we've had some thoughts about how we can make sure we embed feedback better into these meetings so that we are demonstrating to our citizens that we are acting on what they tell us. In terms of the ongoing insight and dialogue, not one-off conversations, again, the approach that Mariana will talk about later looks at how we might do that, and then there are various initiatives taking place. I think the Insight Bank has been here before as well, so that's a really good South Yorkshire piece of work where we're looking at making sure we capture and keep in one place all of the insight that we're hearing from our citizens and have it in a place that is accessible to everyone so that we aren't repeating conversations, going back to people and asking the same things that we've already heard recently, but just aren't connected enough to know that one part of the system has heard it and then another one goes and asks them again. And then obviously, again, the approach that Mariana is going to put forward will help with the openness and honesty and accountability because we'll be having the conversations in a public meeting. Value lived experience. Next slide, sorry, Mags. Again, we wanted to make sure there are various different approaches to including lived experience in meetings like this one. And if I'm totally honest, some of them can seem tokenistic. So Mariana and I and Fran and the ops group have talked about how we can make sure we value lived experience and bring it into this meeting in a meaningful way. And again, Mariana will talk about it later, but it's about through ensuring in our cover sheets, we encourage people to think about the lens of lived experience when they bring a presentation to this meeting, and whether there might be some people who would like to come along. I know we've had people from learning disabilities, autism come into the room, and it really does, I think, add colour to presentations. Working with people that our communities trust. Again, there's lots of work happening around strengthening our approach with VCSE partners. So much evidence around the fact that that's the best way for us to hear, particularly from our underserved communities. Recognising that not everyone is digitally enabled. And again, we're looking across the system at what are some of the ways that we can make some of our meetings less inaccessible, and there's lots of exciting things happening with partners, so we're looking at what we could learn from them, and then finally investing in involvement, and in the next slide I'll take you through the community of interest that we've put together, and I think it's a really good evidence that everybody in this room is invested in involvement and working together in partnership in that space. So to quickly touch on that then, one of the other key themes was about making sure we all work together. We have true partnerships, networks, we have shared values and priorities, and there's a number of quotes there of where people said that in the feedback to us. Next slide, please, Mags. So we have started a South Yorkshire engagement experience and involvement community of interest. It's sort of growing organically at the moment. We've had 120 people who've signed up to it. They're either directly or indirectly involved in engagement experience and involvement. That includes every NHS provider in South Yorkshire represented, including Yorkshire Ambulance Service. It's got every single council. There's 20 council reps on there, the alliances and the collabs, the health watchers, voluntary sector, and wider partners like South Yorkshire Police and Crime Commissioner, South Yorkshire Fire and Rescue, and Bursley Homes. So just very quickly, we've had our first meeting of the, sorry, next slide, Max. First meeting, and this just demonstrates the sort of the co-design approach that we're taking to make sure that people come with us on the journey. So we're looking at the why we want to have a community of interest and making sure we come together with a shared commitment. We're looking at the how in terms of what's the best way of developing our community of interest in a way that will benefit everyone. And then we've also started to look at some of the areas where it had already been identified in previous partnership and stakeholder conversations that we might be able to develop some more system-wide approaches. So some kind of system-wide approach, principles, commitment to how we will involve our citizens. Payment for participation always comes up because it's patchy across the system and we all have different approaches. And is there a way that we could be more uniformed, or at least acknowledge that it's inconsistent across the system, and make sure we're honest with our citizens about that. And then the final thing is around the impact assessment processes that we all have. And as we increasingly work in partnership, all having different systems in that area becomes a bit tricky. Final slide, please, Max. So just a bit of positive feedback that we had after the first session. Lots of people were really interested in being involved. Many people stuck their hands up to be part of a steering group. We asked people to come to let us know what they wanted to do next. There was lots of talk about sharing of best practice, sharing approaches, increasing the range of the community of interest. So we said we would take away to look at a bit of a stakeholder analysis to look at membership, because like I say, it has grown organically. So who was not in the room and might want to be in the room. So we're going to look at that. And then people are really keen. They're already sharing with us any sort of relevant principles, commitments, strategies that we can scope, learn from, look at what the gaps are, what we might want to do across South Yorkshire, and the same for the recognition and remuneration activity. So, and the next meeting is likely to take place in the next couple of months. So that was it really, just a bit of an update from me about what we're doing across South Yorkshire, and I'm happy to take any questions.
Brill.
Katie, thank you. Any questions? Angela?
Thank you so much. It makes quite, it makes really good reading. Actually, it's quite impressive how much you've done in such a short period of time. And I think that it's the thing that we all want, and who's not in the room is always the question that we should ask. But we've had quite a few meetings now, even of the ICP, where we've had no public questions. So my question would be, how do we ensure that people know how to ask the questions, and why that this is a public meeting and yet there is nobody who's not involved in some way with the organization? And it's not just this place, it's any public meeting. Being a council or at a regional level, is the same. So until we have people asking us lots of questions and coming to the meetings, we're getting something wrong somewhere. So that would be something that maybe we can challenge ourselves, as trying to have at least one question for people, because if people are not asking questions, it means they don't know how to ask questions.
That's a really important point. Any other questions or points? Katie, thank you for that update. I think the point, Angela, that challenge is one we should think through. Yeah, I think you're right. We have the same problem at the ICB. Oliver, can I hand back to you?
Yeah, I mean, I just think it's really important that we do get a grip on this challenge, actually. So thank you for the presentation. I don't know the answer to how we get more people involved in these sorts of meetings, and it's similar vein, kind of have that same challenge with the MCA meeting, where we take decisions that relate to hundreds of millions of pounds of spending, really significant pieces of work, and yet all too rarely get people who actually come and engage. When we do, it's really valuable, but I'm not sure we always get that right. And so I think it's worth thinking that challenge through. So if there are any ideas that people have, please do send them through to me. I'm sure Piers and Gavin would say the same about the. But please do send them through to me if you've got any ideas, because I'd be really grateful for sort of fresh perspectives and thinking. Okay, thank you for the presentation. Okay, item number 10, please, which is creative health in South Yorkshire. Lucy, I believe you're going to lead us through it. This is a brief update on partners working together with a focus on creative health right across the region. So, Lucy, over to you.
Good afternoon. My name's Lucy Robertshaw, and I'm the Director of Creative Health Projects at Darts. We're a participatory arts charity based in Doncaster, been running for just over 30 years. We work in Doncaster solely. We're very community development focused. Pretty much everything that I've heard today about moving from treatment to prevention, from hospital to community, to moving from looking at somebody from a disease point of view to an individual, holistic ways of working, it just all rings true. So I just wanted to say that there straight away. And obviously anyone that works within voluntary community service, that's the way that we do things. So it's, we are here. I've come to give you an update on the progress of the South Yorkshire Creative Health Board. I'm interim chair at the moment because unfortunately Cathy McCardle, who was also on this board, has moved over to Cheshire. So I want to just pull out 3 significant achievements from the last couple of months, and then talk a little bit very quickly about the Darcy report and some things that we've pulled up from that, and then a couple of pleas. So I'm going to talk for about 5 minutes, and then we'll have 5 minutes for any questions. Just to remind you, the aim of our board is to influence strategic creative health commissioning so that we can scale up effective and inclusive creative health programmes across South Yorkshire. Every creative health programme that we do responds to the 4 bold ambitions in the integrated care strategy, and at the South Integrated Care South Yorkshire Innovation Showcase that's coming up in November, we're going to be showcasing 2 creative health projects, which hopefully you'll be able to come along to and hear about. There are 3, I would say, significant achievements in the last few months. We've secured funding for a dedicated 0.6 full-time equivalent post to deliver the development of an enabling plan for creative health across South Yorkshire. This has come through funding from Arts Council, the 4 local authorities, and also SIMCA. So thank you very much. That's 2 years worth of actual capacity for developing that. Secondly, and this is just really, really encouraging in terms of the reputation that South Yorkshire has for creative health work, it is huge and it is growing. And I can't state that enough. We are being approached from members all up and down the country, including very successful areas such as Manchester, who've just levered in £1.8 million for creative health work, to Gloucestershire, Bradford, Bolton. We are getting approached to ask about the work that we're doing, the evidence that we're collecting, the academics that we're working with, and South Yorkshire is being seen as one of those real areas of success in terms of creative health. I sit on the Metro Mayor's M10 group for creative health, and again, we're all getting regular updates about what we're each doing within our areas. Doncaster in particular is way ahead. And I'm really proud about that, but I'd also like to say thank you to this board as well, because that has helped us being able to set up the South Yorkshire Creative Health Board and move my work forward. The third area is we are, I would say, leading the way in terms of research around creative health. As we probably mentioned at the last board, Sheffield Hallam University secured 2.1 million for a creative health board's research programme over the next 3 years, focusing predominantly on the Creative Health Board in Doncaster, and then scaling up South Yorkshire and then sharing that learning nationally. This work is very interesting because it deliberately focuses on community assets, such as in Doncaster, Darts, Heritage Doncaster and Cast Theatre, and how you can use community assets to directly tackle health inequalities. So the next 3 years, that is purely what we are focusing on for that research piece of programme. We have embedded researchers, we have annual conferences, we have lived experience steering groups, so there might be something from that we can feed into this group, building research capacity for the community organisations themselves. There will be a separate website for that as well. So as soon as that comes through, I'll send that to you. Again, working with people directly, co-producing arts programmes and working with people in a meaningful way. So I suppose those are 3 things I wanted to highlight and we're really proud of. In terms of the Darcy report, just because I'm sort of here and I've been scribbling some stuff down, creative health has a really vital role to play in building the NHS of the future. We already have shifted to prevention. We already work in communities. We already focus on health inequalities. And the work that we do has been recognised as re-energising staff, NHS workforce, but also trying to re-engage with patients who might be quite far away from engaging with health professionals. The National Centre for Creative Health, in response to the Darcy report, just clarified that creative health can improve health outcomes. We reduce inequalities. We can reduce pressure on the NHS. We are effective and cost effective, and we can reduce demand, all at the same time as having quite a nice time, quite a fun time with other people within a group. So there's absolutely masses. Just a plea again in terms of if we are thinking about commissioning creative health work, all the evidence is there. We have it internationally, nationally, locally, regionally. The evidence is there. If anybody wants pointing in any directions for any particular conditions, then I can deliver that for you. And then a couple of pleas. We are looking to recruit for a new strategic chair now that Kathy has left. So we'll send those details round. We're looking for somebody who has a real interest in, doesn't have to be in knowledge, but an interest in creative health and how it can tackle health inequalities, if that's something that you are curious about. Somebody who has influence at a strategic level in health or social care, and ideally somebody who has a role already on the ICP or ICB. All the details can come out. There's already a Creative Health Exec Committee. There will be a 0.6 post in place. So essentially what we do is we have the support for you if anybody is particularly interested in that and wants to apply for that. Yes, and the other thing is, please come if you would like to. I'll send you a proper invite out, but on May the 7th at the Point in Doncaster, we're going to have our first Creative Health Conference as part of the UKRI Creative Research Programme, and that's where we can find out about what's been happening in the last year. There'll be people's lived experience, there'll be examples of programmes, the academics will be speaking and talking about some of the evidence that they have so far. I think pretty much that it. I suppose the only last thing that I would say is Greater Manchester 2 weeks ago secured £800,000 from Arts Council from Place Partnerships, specifically for their 3-year creative health programmes across Manchester. That has now levered in an extra £1 million, and that will grow. That's what I would like for South Yorkshire. So there we are. That's our challenge. Yeah, I'll stop there and answer any questions.
Lucy, thank you. Any questions, any points? It was really great, really interesting stuff. Thank you. That's an update and a plea.
A couple of pleas in there, yeah.
Is there some...
Okay.
I don't know. Rachel, were you going to say something?
I feel like I've talked too much, but I feel like I've talked too much, but I'll sneak in with one. I think what Lucy's just presented there answers some of Oliver's question on the previous item, which is about how can we get inputs and contributions to meetings like this and some of the other more stuffy meetings that we hold. And it's for things like this, it's probably not a build it and they'll come for all sorts of reasons that we'll all understand, but there will be co-production type methodologies where we can engage people through arts or other things that are much more attractive than a warm and stuffy office. So I think there's perhaps a response or support for Oliver and to Katie and some of the other things that we've heard about today.
Oliver, can I hand back to you?
Yeah, thank you. I'm shocked to hear that people think that the ICP meeting or maybe the MCA meeting is a stuffy meeting. But no, I take the point entirely. Thank you for that. Just worth me saying, maybe I previously worked for Book Trust, and they give out 3.5, or at least when I worked there, gave out 3.5 million books a year. We're now engaged in a process of trying to work out how we can make every child a reader in South Yorkshire. And I'm not saying obviously kind of creativity is just focused on young people, but I do think absolutely kind of there is a real opportunity to do something quite special in South Yorkshire when it comes to health inequalities, access to opportunity and creativity. And I'm a big believer in the role of creativity in solving some of those problems. So I thought that was a brilliant presentation. Thank you. And it's really gratifying to hear that South Yorkshire is leading the way. And we have to do more, of course we do, and kind of getting money in like Manchester seem to have done is of course important, but really nice to hear that we're doing so well. So thank you for the presentation. Okay, this is item number 11, which is an integrated care partnership development report after the session that we had. So interested to hear on sort of feedback from the operational group on next steps, and Marianne, I believe you're going to lead us through that conversation.
Lovely. So this last item today is really to share back some of the themes from the development session we had at the end of July, and also the thinking that's taking place in the operational group about how we develop an action plan based on those themes and what it is we do in terms of supporting the onward development of the partnership. So I'm mindful that you've all had opportunity to have a look at the paper, and I don't have any slides, which, given we've seen probably quite a lot of those today, I thought you'd appreciate. But what I'll do, if it's okay, is just pick out a few of the key points from the paper. So the first thing I wanted to pick out was really about context. And, we've heard already today, haven't we, about the publication of the independent investigation into the NHS, the Darcy report, and, the now awaited 10-year plan. And so I kind of wanted to make the point about the opportunity that we have in South Yorkshire in terms of, contributing, influencing and informing the development of that, and how we're really keen to ensure that the health and wellbeing boards that we have across each of our places and the ICP are enabled to do that. So when we come back together again, which is actually towards the end of November, what we're hoping that we'll be in a position that we'll know a bit more about what the shape of that plan might look like, and we'll be able to have a kind of further conversation around that. The other thing that I wanted to pick out is you've got a bit of a summary in the paper about some of the themes. So if you remember, those of you that participated in the development session, what we did was we took a bit of a look at understanding where we're at. So in the paper, there's a link to our outcomes framework. There's a bit of a summary in relation to what we understand where we're at in terms of the bold ambitions. We also did a bit about what we think is working well and what we can improve. And I thought some of the things that would be helpful just to pull out is that there was a real consensus about the level of commitment to our strategy, and the fact that, the partners are here in terms of a joint commitment, looking at how we work together to add value. And that's been evident today, hasn't it, in terms of some of the presentations that we've heard. But there were areas where we knew we could improve. And some of that was about how we might strengthen and broaden our membership of our partnership. And some of that was about how we build our connectivity in terms of our health wellbeing boards, our place partnerships, and all of that kind of thinking has informed the development of an action plan. So what you'll see in the paper on pages 4 and 5 is that, based on the feedback, what we've done is identify kind of 6 areas of action. The first one being about continuing our journey to collaborate so that we can really maximise the value of the partnership as a system convening partnership, and doing that in conjunction with building our connectivity with our health and wellbeing boards and our place partnerships. So some of that's about looking at that kind of balance of meeting in public, but also some of the development time, because I know that people really value that as well. The second one's about strengthening and broadening our membership. So there was a number of conversations when they were about the balance around statutory and voluntary membership, and looking at how we think about things like diversity, representation. There were a number of areas where we've got potential gaps that were identified. So we've got a proposal there to develop a bit of a membership review proposal, and so we'll undertake some work on that ahead of when you come back together again towards the end of November. The third one was around enhancing our forward planning. So we have started to get a little bit more organised on how we're thinking ahead in terms of our forward planning. So it is around how we build on that, how we engage our health and wellbeing board chairs to inform that, and how we get some of that balance right between sharing the good things that are happening in each of our places and across South Yorkshire, and enabling that conversation about what more could we do. And I feel like we've tested that out a bit today, haven't we, in terms of trying to look at how we get some more of that balance in the way that we come together. The fourth one is around how we focus on kind of action and deliverables. And this was really about, us as a board thinking about how we utilise our action log. But it was also about thinking about the approach that we might take in terms of supporting some of the work around each of the bold ambitions. And, whether we could employ some of that kind of more workshop type approach, and how we involve people in how we do that. And then within there as well, how we think about how we develop that feedback mechanism. So Katie referenced some of the discussions behind the scenes that Health Watcher colleagues are having about how we build that into the business of the board, so that we're really taking that kind of you said we did type approach as we go forward. The next one was about strengthening how we monitor progress and how we link to our outcomes framework. And that was really about us taking a bit of time to consider whether we think we've got the kind of right set of measures that scaffold the ambitions that we want to deliver. How we try and use our kind of collective leverage where we've got challenges. So thinking about, some of the, data sharing was one of the things that came up earlier today, wasn't it, as a challenge, so how we as an ICP get behind some of supporting some of the, how we unlock some of the challenges in that space. And then the last one was really about ensuring sufficient focus on our enabling plans and our joint commitments. So we've heard a little bit about some of our enabling plans today, haven't we? So we've heard about kind of, the opportunities around Start With People strategy, and we've heard about the early work to develop the kind of creative health. And I think there's something about understanding those enabling plans and where they are and what is it we need to do in terms of their onward development. And then revisiting the kind of joint commitments, which you remember in our strategy, they were almost like the challenging how part of the strategy, weren't they? And so, you know, understanding how do we identify and test ourselves in terms of how we're acting in line with them. So they were the kind of 6 areas of action that I identified from the themes in the development session. The last bit of the paper really starts to talk about some of the actions we're already starting to take in line with those. So the development of a membership review proposal, looking at how we can make these ICP meetings more inclusive. We've actually got some really good examples of how organisations are starting to do that. So health and wellbeing boards, looking at the language in their papers. Some of the organisations like RDASH are going, you know, a step further and thinking about how they're being inclusive in their approach. How do we support people that come to the board to think about why they're coming to the board and what it is they need from you? And there are some really good examples of how we've got some guidance and support for presenters, so we can ask them to think about things like how they're using data differently, how they're thinking about lived experience. So there's a number of things that we're looking to see what we can put in place to support presenters as well as the board itself. Work to look at how we strengthen citizens' voice in terms of how that comes into the board. So how do, I mean, you've heard a bit of some of the kind of lived experience coming through some of the presentations today. So we're really trying to start to think about how do we build that in. So that's kind of part of our normal business. And then the last bit of the paper was really about some planning behind the scenes that a number of colleagues are involved in to look at a workshop that focuses on the ambition that we've been focusing on today. And a lot of the discussion that you've had today will actually inform some of the shape of that and how we take that forward. So in terms of the recommendations of the paper, then it was to note the opportunity that we have as an ICP in terms of contributing to the 10-year health plan. That does feel a little bit like a watch this space at the moment, and hopefully we'll learn more before we next come together. Note the key themes from the ICP development time together, and hopefully they feel kind of familiar in terms of how we broke those together, particularly the 6 areas of action. And then the work that's already underway that's in line with, acting in line with those kind of key themes that we've identified.
Mariana, thank you. Really helpful update. Any points people want to raise? Bill.
Yes, this is my first ICP. Thank you for having me. I thought that the items were interesting, but maybe we didn't have the bias to action that we'd ideally want. And I worry that the way these objectives are expressed, there's some quite passive phrasing around developing and so on. So I think if we want to build confidence, for example, around South Yorkshire people being alongside us, they'll need to have more confidence we're going to get stuff done together. So it might be thinking about how we phrase this in that way.
That's really helpful and a helpful perspective of a couple of first meeting, and nice to see you, Bill. Yes. Gavin.
Yeah, I just wanted to pick up the points around the 10-year health plan, and you know, if you look at some of the I guess the messages coming out of the new government, the focus on the shifts, you know, towards prevention, you know, out of hospital. We've actually spent a lot of time talking about some of those issues this afternoon. So if you think about that kind of diagnosis, you know, it's not that dissimilar to the conclusions that we've reached as we've developed our integrated care partnership strategy. So I guess what's on my mind is, although exactly how we might influence and input into the development of the plan might not be entirely clear, I think we've got a lot of traction already in the right sorts of places. So whether that's, you know, the focus on children and young people, whether that's the work and health relationship, health on the high street, you know, all of these things, prevention, quit. I do think there's something about marshalling the story that's already emerging in South York to be ready to feed in to the plan. So I do wonder whether there's a bit of work we could do collectively, whether that's through the operational group, but begin to marshal that story.
Mariana, thank you. Oliver, can I hand back to you?
Yeah, brilliant. Thank you, and thank you, Mariana. There's obviously a huge amount of work going on, so appreciate all of that. I mean, I agree with Gavin's comments there at the end. You know, telling that story is hugely important. I'll do my best whatever I can in that sense as well. I'm conscious of time actually, and the fact that I was clearly overzealous earlier when I was moving along colleagues from the QUIP programme and the Tobacco Alliance. So before we move just to the kind of wrap up of the meeting, are colleagues still in the room? Lisa, Leanne and Sarah, are they still there, or are they? Yeah.
Dan, is there anything else you want to get out of time?
We're just giving them opportunity. There's one person left. They're going to have an opportunity, Oliver. Okay.
Right, just because we do have a bit of time left, so I just wanted to give you that chance. Sorry, I was keen to get the timing right, but.
Hi, Oliver. It's Leanne. They weren't the slides that I was speaking to, but what really was our objective was to try and get a bit of a discussion within the room about what individual organisations could do to overcome some of the challenges that were included in the slide deck. So I mean, I don't know if it's worth us going back and just kind of reflecting if colleagues have had time. We've had a bit of a discussion in the break as well about how we might circulate to yourself and to chief execs of local authorities some of the challenges that we're coming up against. Spoiler alert, a lot of it is around governance, which won't surprise you. So yeah, I don't know if
rather than, because I think it might be quite difficult to reopen the discussion. So rather than doing that, then why don't I just say, if you can then, having had some discussions in the break, and obviously everyone now knows you around the table, so if people can feed into you what they think might need to change or be done, and then maybe you could write me a note, and I can take those actions on board from my perspective about what we might be able to do through the ICP or through the MCA to be able to kind of move that forward. But if you write to me directly, include Stephen in that conversation, obviously, then we can take that conversation forward in that way. Is that okay?
That would be fantastic. Thank you, Oliver. And I'll feed that back to Sarah.
All right. And sorry to have rushed you earlier, but great. Thank you for that. Okay. All right. In which case, can we move on to just the wrap up of the meeting then, which is just any other business or any concluding comments that people might have?
None in the room, Oliver.
No, brilliant. Thank you. Okay, in which case we're on to date of next meeting, which is just the 28th of November 2024, so just back end of next month. Thank you everybody for the time that you put in today and all the work that's gone into the meeting. I think that was a really brilliant discussion. Actually, there was a huge amount on the agenda, but in terms of that focus on the bold ambitions and acting differently together, I think that is a really good example of where a load of work is already happening and where, as we heard, South Yorkshire is already leading the way. So thank you everybody for the work that's gone in, and we'll see you at the back end of November. Thanks.